Isabel.
Thank you, JC. Thank you.
Welcome.
Welcome, everyone, and welcome back. If you were able to attend the kickoff session on Thursday. If you were not, I want to point you to the website. So I'm going to share my screen right now, and I'm going to show you where you can find all the information about our event on Thursday night. If I can get there. There you go. Okay, so you go to this website, gahealthcareinnovationchallenge.com. And if you look at the challenge, and Dale's challenge is the first one. So for those of you who were on the call this morning with Laura Gentry, we're doing this a little differently this afternoon. You can get the full deck right here. We're not going to go over the deck again because Dale really wants to give priority to your questions. And if you go to resources, you can get the whole recording from the whole event right there. Okay, and there's a lot more resources and documents that you can refer to. So I'm going to stop sharing, and we'll do this differently from this morning. I know I recognize quite a few faces and names. So thank you for your interest. Thank you for your curiosity. Thank you for coming back. And we'll get started with Dale Boylston, the CEO of TC2, the ACO in Middle Georgia that includes 4 health systems. And Dale will get started and address your questions. So without no further ado, go ahead, Dale.
Okay, great. Thank you, Isabel, and good afternoon, everyone. You know, as Isabel indicated, we spent 12 to 15 minutes covering a lot of territory when we talked on Thursday night. What I realized, even with some of the questions that were coming up afterwards, is a little bit of additional clarification is probably in order. So I thought I would take 3 to 5 minutes on the front end and try to add a bit more clarity to the issue as we see it, which I think will help frame and even prioritize some of the questions that we're obviously trying to respond to as generated by you. So as you well know, TC2 is a track-free Medicare MSSP, and therefore we have both upside and downside risk. When we began to talk about our challenge on the issue of identification of rising risk, it really relates to a couple of things. The sources of data that we're able to use today, okay, I'm going to talk briefly about those, and essentially the analytic capacity that we have for drawing effective conclusions from that. And then third, the role that we're expecting that the participating practices will play vis-a-vis my team members. So let me kind of go through those in order. The data that we typically receive is a CCD file or a CCDA file, I've heard it referred to both ways, that essentially is generated, okay, by Medicare to essentially our population health management tool called Health Endeavors on a monthly basis. The real job of Health Endeavors is to take what is a machine-generated form, the CCD or CCDA, and turn it into something that actually is to some degree readable by us. That today is our primary data source. Secondary data, and that is a full-blown, covers every particular instance on which a patient touches the healthcare system, on which an invoice is generated, whether or not that invoice is paid or not, including diagnoses as recorded. Again, as recorded ends up being a certain element, and occasionally even a little bit of the diagnostic lab results, but that is rare in most cases. The secondary data set, that we rely on, which I refer to more as our pull data set, really is what we essentially gather in terms of quality metrics and to some degree lab results. In those cases, it is our effort to reach out directly to the practice EMRs and pull that information as it stands today. For the quality metrics, we essentially are looking at certain things done. A few of those are increasingly showing up on the CCD because they actually now have a code attached to them, but a number of them don't. So for us, we are heavily reliant on claims data, general demographic data, okay, and then selective ability to pull that additional information. And again, when I say claims, it still includes a lot of the diagnosis information. So we've got a pretty good picture as to the conditions on each. So from our standpoint, that all gets sucked into or pulled into health endeavors. The second data set that I was talking about either is directly submitted, those quality metrics, sometimes lab results or other diagnostic outputs, are either submitted by the practices themselves because they actually have access capability, to health endeavors, or our team members go into the EHR and pull it from those EHRs. We have 85 different practices. We have EHR lookup capability on all but about 5 or 6. And of those, there are still a few on paper, but 75 plus practices, we have those lookup capabilities as it stands today, but again, on a pull basis. So from our standpoint, one of the challenges is we have new data sets that are likely to be coming in the near term. For example, we are actually in the process of doing practice assessments right now to make sure that as practices are beginning to participate to some degree in HIEs, either GHIC as a statewide HIE, or one that we call Care Quality, which is a national HIE that we actually see as very, very promising given its ability to move data. We're now working with the practices to make sure if they're putting that information in the EHRs, they're putting it in the right place. So actually, we're not in a garbage in, garbage out scenario, but things are appropriately done. And that will be done this year. So we're going to be getting tools to access more of that information. We additionally get ADT feeds, admission, discharge, transfer feeds from each of the health systems on a regular basis. Now, the problem with that is everything I talked about from the HIEs themselves, which we're not really using much of yet, but will be in the near term, and certainly the ADT feeds and any other elements are not effectively integrated into health endeavors. It's primarily a tool to help us focus on the aggregate claims and all the data in that claims activity and any other quality measures. So from us, when we get that, we also have pretty limited data analysis capabilities from health endeavors. They have a large number of quick reports that are available. They have a simplistic risk stratification model that we find wholly unacceptable as a tool for us. So when I think about what we then as a team need, and the team would be my folks who are primarily using whatever solution we're able to come up with here, would be the ones who then are able to pull together not only what we're getting today through health endeavors, but other disparate data sources in a manner where we're getting a full, complete, longitudinal view of these patients, and we're essentially enhancing our predictive modeling capabilities by having a richer data set. I mentioned the limitations of patient risk stratification from the tool we have right now. A short way of summarizing is they have 4 tiers, but the top tier, which they would consider high risk, is really simply, did you have an HCC score in the top 30%? Okay, now remember, we've got almost 24,000 members, top 30% HCCs. Do you have 3 or more chronic conditions? Did you have 2 or more hospital admissions? In other words, it's largely activity-based and simply diagnosis-based without any other additional insights generated. And that tiering, as I said, we have largely ignored because, frankly, it doesn't help us much. So we actually then, have to go through and pull from different sources of data or the different reports they have. There's no integrated view that we can take. We can look at patient summary demographics, but if we want to see their HCC history, not just for this year, next we have to go into another report. Pulling those things together, they all come down in an Excel file, ends up being very, very difficult to manipulate. So you begin to see that while we have a lot of data, we don't have a way to take in new data sources at this point in time that we can effectively integrate it. And while even as we get more of this data, we have no organized way to truly do leading edge analytics that allows us not only to theorize the factors that are maybe driving behaviors, but actually explore those for their statistical relevance. One that always comes, or there are a couple that come up for me just to make this realistic to you. One relates to, dialysis. Actually, a couple relate to dialysis because they end up being very, very expensive. For example, we use a lot of different dialysis centers. We've theorized for some time that what we call high port access complications, in other words, port access is how you actually connect in when you're doing dialysis, correlates to a high number of ED visits. And we ought to be able to rank who we really want to work with of the dialysis centers on the basis of being able to pull together those two disparate data sets. Well, today, we have to do that manually if we're going to get some insights. Another is what we call, say, crash versus planned starts. And what I mean by that is a patient who is, at risk of renal failure, progressing through what we call the CKD stages. If we aren't able to catch them before they go into higher risk, in other words, already diagnosed the first time they need dialysis, they'll be what we call a crash start. Ambulance, emergency room, long hospitalization, slow recovery, $100,000 overall price on average. A planned start, usually $2,000 to $3,000. You can see the difference of being able to integrate in that earlier. So when you think about this, think about the flexibility in terms of pulling those disparate sources together, the flexibility in terms of allowing for, very, very solid analytical capabilities to test almost any theory or idea we have of interrelationships. And the real acknowledgement is we're largely trying to make sure most of this capacity is centralized for the basis of my staff at TC2. There will be some practices that actually want to make use of the analytic tool as well, but most of them will be submitting the data and then pulling standardized reports. So a lot of the flexibility I talk about here is more aimed at TC2 as the user. So let me stop right there, as far as the initial commentary. I didn't want to go too long, but I felt a good 5-7 minutes of an overview would be helpful to frame what we're thinking about so that we can target the questions more appropriately. So with that, I guess, JC, do I turn it back over to you?
Yeah, sure. I've got a lot of questions. I'm going to try and they do kind of fall all over the map. So I'm just going to try and bucket them a little bit. But if anyone, again, does have specific questions as he's going, feel free to chat them. But I'll go ahead and start with first. When is this current data set that's being received, when is that available? Is that available today, or what does that look like?
Okay, that data set, the primary data set is the monthly CCLF file that we get from Medicare. We get that by the 20th of the month for the previous month, every single month. We also get a quarterly update that adds some additional detail. That is the primary data set. So we get that every month on a regular basis. Okay. It has to be obviously ingested and then made available to us, usually within 3 or 4 days after that. Okay.
Perfect. And I guess, so some people have been saying, like, is it possible to get a few samples of that, of anonymized claim data, or is that something that they get right away? Because they're saying for a quick review of what type of source data is out there, and sample output / results, that would help ACO make an informed decision. So is that something
right.
where,
okay.
Yeah.
We can do, but here's the simplest way to answer. For those of you who have any familiarity with healthcare system reporting, what we get, or what Health Endeavors gets, is essentially the CCD or CCDA file by patient with every claim every month. That is a machine readable form. And what we can do is basically all that Health Endeavors does is organize all the elements collected in the CCDA into a form that we can then download in different Excel reports. But what we can do is give you a listing then of the reports, but see, that is more the output. I'd like to think of it more in terms of look at a CCDA, identify that once it's processed, every one of those elements is available as a discrete data field. And then obviously what we're looking to do is find a partner that can help us not only build off of all of those data fields, but add to it. What I can do is I can ask to see if one of our tech folks can get more or less a listing of that, but it is everything that is available through a CCDA if data has been submitted in that particular field.
Okay, great. One question is, can you articulate what an ideal workflow for your team would look like besides getting an aggregated longitudinal view of data?
Well, I think I would say that's first and foremost the first thing. I started my commentary by describing what we have to deal with today, which is there's a long list of what we call quick reports that are available through the tool we have today. But again, I consider them each kind of one-dimensional views from a particular perspective, and it's not organized in a way where we can pull it down on a broader basis. So when we have that, what we do have is this. A huge number of theories as to interrelationships and predictability. You can call those algorithm theories, things that we believe are contributing factors on the rising risk basis, which if we don't have time to manually test on a broad basis, which I'd say 95 times out of 100, we don't, because of the difficulty in just pulling together some of the data to begin to look at it in the limited data set we do. It's really that. So if we can pull it together, and again, you're going to hear this from a guy who is very technologically challenged. I'll leave it at that. I envision, the ability to take from that and create more or less a data lake where we have the ability to do focused queries, but have the flexibility to do queries, based on some proven algorithms that we can identify, already, some theorized relationships that we would like to very quickly test, and if so, then routinize, and some others that maybe we just analyze on a broad basis and say, is there anything else that we're finding here as conclusions or interrelationships that do help us with early identification of a particular, challenge or a rising risk condition that we ought to be paying more attention to.
I think that's important what you just said, Dale, and I want to stress that. I think, Dale, if I understand correctly, you do not have a technical person on your staff. So it is important that the data, is digestible in a way that can be insightful and that can be actionable for all the team members of TC2.
That is correct. I have a number of very smart clinical folks who are always saying, I wonder if we could do this, would that make a difference? And we look into it and we go, it'll take us a week just to do that kind of an out. We don't have the time for that. We're busy taking care of patients. But a lot of those insights are either already developed, but we have to manually apply that patient by patient because of limitations of the current reporting, or again, they're theorized. And we don't really have the ability to effectively test that in a significantly statistical manner. So we're maybe trying it as a one-off, but it's not effectively something that we can or have been able to deploy broadly. All of those things, again, going back to that example, the crash versus the planned start, catching patients before some of these issues really crop up, or before we have that high intensity, high cost episode, is what makes the difference here. And the better we can use clinical insight to test theories and to apply those that work to affect that change, the more significant this is going to be.
What are the highest cost type of diseases for you? You mentioned chronic kidney disease, CKD, cancer, probably. What are those very high cost types of encounters?
Yeah, let me give you an example. You just asked about cancer, and I'll tell you how we deal with that, which to me is suboptimal because there's an issue. In most cases, a cancer patient already has what we call a clinical navigator outside of TC2. In other words, they're being seen at a hospital or at a practice, and there's already someone who's helping them navigate the very difficult process of coordinating all the treatments, all the tests, all the follow-up that need to be done. But we've started to theorize recently that not every one of those patients has an effective navigator relationship. We in the past have kind of pushed them off of our high-risk list and assumed they've been taken care of. But we don't really have the ability to validate that unless we look at every single patient record that fits into that category and determine, are they being served? Is there a better way to do that? Because right now, we can't. So that was the cancer answer. We did talk about CKD stage 5 leading to renal failure and dialysis, end-stage renal is obviously very expensive. The average ESRD patient runs us close to $100,000 a year on average. Well, maybe 80 to 90. I'm probably exaggerating a bit. If they have an issue, it goes north of that. But the other chronic conditions are the ones that you would expect. And they usually are in combination: diabetes, hypertension, COPD, CAD, peripheral vascular disease. Those are the ones that come up most frequently. The question, though, is we're looking at the interrelationships. How do we, work with a partner where we can evaluate based on a relatively large data set, looking historically, are there some interrelationships of those chronic conditions that make them more likely to very quickly move from, into and through rising risk into high risk? We don't really know. How do we integrate some of the best practices learning and essentially put in place some algorithms to do that? Again, not something we can yet do. This becomes much more of a one-off patient management issue, and with limited staff, more often than not, you're trying to be as proactive as you can. But again, we're usually, working very closely with these patients after they've already become expensive, which is kind of like, the horse is already out of the barn. That's the way to put it.
Okay. I've got another question here from Eric, and he said, well, a couple. He said, how are you stratifying your risk? In other words, how are you designating someone as high risk? And are you specifically looking for a responder to advise/provide best practices on risk stratification?
Okay, so again, I hear two separate questions here. Let me go to the second one here. Advising practices on risk stratification really is HCC training. In other words, helping physicians understand. A perfect example, two of the best examples of this, if you code diabetes uncomplicated, even though that patient has additional chronic conditions, that has a very low weighting in the eye of Medicare, which means the patient isn't as sick. We train physicians how to code at the appropriate level, which we call appropriately documenting the burden of illness. So I feel that with the practices, we already have the training mechanism in place. I think I described when we did our presentation Thursday night that we have an average HCC score across our practice of closing in at a 1.5. And we finished last year at a 1.46. We're trending ahead of that this year. So our physicians are doing, I think, a fantastic job of coding due to the training and support we provide them. But there are two ways by which you succeed in this model. One is effectively coding for burden of illness. We're covering that. The other is identifying those patients early enough to treat them before they become expensive. That is where I feel we are not nearly where we need to be. So on the first question relating to the risk stratification, I think I outlined at the beginning of this conversation, but the tool that we have right now does a very simple 4-category, tiering of patients from, high to low risk. And I'm going to read to you because I have to look, I've got it right here, what puts them in as a tier 1. Which is, in their vernacular, the high risk. They're in the top 30% of HCCs either this year or last year. They have 3 or more chronic conditions. They have 2 or more hospital admissions in the previous 12 months, or 3+ emergency department visits in the previous 24 months. Now, here's my problem. I've got almost 24,000 lives. Do you want to guess how many fit that top tier? Almost 40%. I can't manage that many folks without some additional insights and capability. So this tiering, this risk stratification, as I indicated when we talked Thursday night, hasn't been helpful to us. We've largely ignored it, used elements of this plus some of our own judgment to do our own risk stratification. And I don't feel that is essentially up to the task.
Yeah, and it's too late by the time they already have so many emergency rooms. And
well, if it's claims-based, and remember, the data that we get is paid claims, and that's something that I know I highlighted Thursday, did not hit yet. Paid claims are going to lag the actual experience by 45 to 75 days. We've had experiences where, a patient shows up, we get the claim that shows that they are in the emergency room, but between the time they went to the emergency room and we got the report, they not only went to the emergency room a second time, but they were admitted. and that data won't show up until the next month.
Mhm.
So the lagging aspects of this require some predictive modeling based on history, and that's another limitation of the system we have today. It deals with each contract year, which is a calendar year, discretely. But if we're looking at trending, Medicare provides us 3 years of historical data for the folks that are attributed to TC2. How do we use that historical look back to do predictive modeling going forward? It's a rich data set, but we have to look at each year separately, okay? We get sim insights from the immediate previous year, but we'd love to look at 3 years overall if they've been with us for that long and really see if we can't draw better conclusions, from really, the trends in their overall activity and the mix of that activity and who they're seeing and the resources they're using.
Okay, I've got a lot of questions, so I'm going to try and kind of pull some up. This is a two-parter, so you might be able to speak to this a little bit. So first thing is this central patient management done in a centralized manner by an MD, RN, or a social worker, or is it done by one of 80 participating physician practices? And then to follow up that, maybe you can just describe your current care management program.
Right. Okay. The answer to the first question is both. In other words, we try to engage the practices because they are the ones that have the patient relationship. But what we have is we actually have a centralized decision support structure within TC2, and then we have 5 regional, actually right now, 4 regional population health centers. Okay, 1 in Macon, 1 in Warner Robins, 1 in Cordele, and 1 in Douglas. Each of those is comprised of kind of a part-time director with someone who is responsible for telephonic outreach, someone who's responsible, a social worker responsible for evaluation for social determinants of health, and paramedicine outreach, a paramedic who we can send out. So decision-making and the prioritization of the overall effort is centralized. Individual decisions about our outreach is specific to the region because we are geographically spread, and we want local population health centers working with local physicians because those physicians know the individuals then they're working with rather than some remote interaction, which is what many payers do, which, by the way, physicians absolutely hate. So we try to make it a local exercise. And then we engage the physicians. We meet, our team, the central team, meets with them every month to go over where they are with these patients and continue to review who needs follow-up, what kind of follow-up, so they really feel part of the process. And obviously part of the responsibilities for follow-up are handed back to them, and part we take over, either centralized or through the population health center. So it's really a coordinated model that we use. There were 2 questions in that, right? I think I've forgotten the other one. Sorry.
It was just kind of a generic, like, can you describe your current care management program?
Well, the current care management is analytic on the top end to identify those that we really feel are high risk, okay, summarized from this larger subset I described earlier. And then these local population health centers that are charged with addressing the needs of those high risk folks. Again, telephonic outreach, is it just an issue of getting a patient to, be more medication compliant? And if you could just remind them, several times a week of how they're doing and what have you, along with a history as to whether or not they're feeling the meds or not, that's great. Do we have social determinant issues that we need to address? Transportation, family violence, food insecurity, or those things? And how do we bring in some local services to help address that? Because it's some of those issues that oftentimes, are driving their activity level. And then third, again, if somebody is sick enough where we're really working hard to keep them out of the emergency room and therefore out of the hospital, we will on occasion be sending out a paramedic to the home to do an on-site review and to check on the patient in person. Okay. And that model is localized again in each of those 4 regions.
Great. I'm going to skip over a little bit to some of the technology. Number one, is there any specific requirements on the technology side right now that you guys are requiring?
No, other than obviously meeting HIPAA standards and making sure that we have the appropriate data security in place. No, because really we're looking at this from a user perspective. Is, I mentioned and Isabel reiterated, we don't have tech support really on stuff. We can access some of them to do what we need to do, but primarily, we're really running with clinicians who are more focused on using the data. So we're very flexible about how the solution is structured, as long as it's very, very usable and flexible, because that's truly what we need.
Okay. And I assume, so like a cloud-based solution would be acceptable, like it doesn't have to be on-prem, anything like that?
Everything we do is cloud-based. We're absolutely A-okay with that. We access Health Endeavors cloud-based. So no, we have no problems with cloud-based.
Okay. One question was, how will the system recognize a new patient assigned to TC2?
Well, that's an easy one. Medicare, we are a prospective assignment because we're at risk. So we know in November of the prior year who is attributed to us for the entire upcoming year. We don't have surprises. The only thing we have is losses over the course of the year, because a patient either passes away or they choose to move to a Medicare Advantage plan, which takes them out of the MSSP program. That's it. So we know who, and we even know who they're attributed to. In fact, we usually spend December and early January making sure the attributions are correct, because Medicare does the attribution saying that, and Mrs. Jones belongs to Dr. Smith. Well, we talked to Dr. Smith and he goes, I haven't seen Mrs. Jones in 3 years, and we look back and say, well, who's treating her right now? We have to then reassign. So we do that, but all of that, if not done by the end of the prior year, is done at the beginning of the year. So today and for the remainder of the year, we know exactly who we have. There are no ads.
Okay. And then, so would there be active participation from a patient, i.e. does TC2 expect anything to be done by the patient, or is that on your end that you're classifying or interacting?
No, we're not expecting any interaction with these data sets from the patients. This is for the use of the TC2 staff, either the centralized staff or those in the population health centers, to manage the patients effectively. In fact, even when our population health center folks reach out to a patient in a local area, we do not identify ourselves as TC2. That just confuses them. Who's TC2? We say we're calling on behalf of your doctor's office. We're calling on behalf of Dr. Smith, your physician. We're calling on behalf of Dr. Roberts, your physician. So in that way, the primary relationship we try to maintain is with the physician and the patient. We are there as kind of invisible support.
Okay. And so, I mean, even though you're saying there's no participation, would there be any desire for that? Would that be something that TCT could enforce active participation by that, or, especially like medical adherence or anything, or no?
Well, I would say you're raising a good question. I haven't highlighted this because this adds a level of complication to what we're talking about here. But think about remote patient monitoring. Okay. If there's a time when we can make that acceptable to some of that and essentially have those tools in place, the ability to integrate RPM data, okay, into what we're talking about here would be extremely valuable as a means of outreach. That's not part of the current plan, but that's another one that probably fits into the how might we incorporate that in the future. Because the cost of the RPM tools is becoming so inexpensive right now that was cost ineffective for a lot of our folks 2 or 3 years ago. It's definitely becoming cost effective. Okay.
So one thing, and I know you guys have mentioned this, of course, you definitely want to have a beta, you want to, bring people into this, but a specific question was, will TC2 take an active role in helping the vendor or whomever integrate the different providers into their system? And I assume this is a yes, because you're willing for it to be a beta test, but that was one thing, maybe they're looking for clarification on that.
Well, again, the integration on that sense, to some degree in terms of lookup capability is already done. So I guess, again, being, technologically inept, what I would say is we're obviously already getting the CCD files and obviously the summarized data through Health Endeavors, which is all the comprehensive claims, we already have lookup capability for all those EMRs that were ever going to be able to get lookup capability. As I said, a few were on paper, and there are a handful that just refuse to give you access for whatever reason. You'll always find a few physicians. Usually they're independent solo practitioners. So I'm not quite sure where that's going, because by and large, the only difference would be, might we be automating, some download of the information from the EMR rather than the current manual pull. Well, that's where I see integration with the HIEs coming into play. And one of the reasons we're doing at this point, or will be doing through the remainder of the year, an assessment of the practices to make sure they're putting the right data in the right places in their specific EHRs, so that GHIC and/or care quality, can essentially be pulling that. So some of that, I think, one way or another, I think that's already going to be done. Okay,
great. Yeah, it sounds like you answered the question. So perfect. So, and you may have touched on this, but I just want to make sure and ask it. Do available interventions affect what beneficiaries are addressed in a month?
Is that a question? I'm not quite sure. I mean, we obviously prioritize our interventions to the population health centers in terms of what we think these patients need, and we learn as we go. As we get new data, that may sometimes certainly change our priorities in terms of who's higher on that priority list for the population health center to work and who's moved down a little bit. I'm not sure if that's answering the question, though.
Maybe
our interventions are driven by what we know about the patient, what risk we think they have of an ED visit or admission or readmission in particular. And yes, that information is updated on a monthly basis. Actually, even more frequently if we get other data sources.
Okay, great. If they need clarification, feel free to chat, Aldo.
Great.
Yeah, it sounds to me like in an ideal world, your population centers would know exactly what, if they know what the rising risk patients are, they know where to focus their energy and their efforts. And on top of that, I'm sure they are managing the high risks already. But if they can, focus their efforts on rising risk, it would be maybe a good use of their time as well.
It absolutely would. In fact, one of the things that I would point out is right now we're busy enough with the high risk and selective rising risk that when we can more effectively identify them and we can document that our insights and the algorithms are helping us pick the right folks to focus on, I would expect we need to substantially increase the number of staff that we have taking care of this population. It becomes a much easier justification, when your hit rate in terms of knowing, who are the rising risk folks to pay attention to improves.
Okay, great. It sounds like you're kind of touching on this, but this was one of the questions. What does overall success look like after the beta, right? Whether that's staff or something. And Isabel, you were saying the identification. Maybe you can just speak to kind of like overall success, kind of defined by you.
Okay. Well, overall success, for me, would have a couple of components. Number one, we have, easy access to a comprehensive longitudinal data set that really allows us to take those algorithms that we know, tend to work for actually effectively managing both the high risk and identifying some of the rising risk, can be done easily. Secondarily, it supports our ability to theorize and identify, interrelationships or relationships that improve our predictability over time, so we can quickly test ideas and look at the data sets associated with it. And that information can be readily made available to our population health centers for their activity and back to the practices in a timely manner for them to effectively work with their patients. Because again, all we try to do is think of us as practice support. When something comes up and we even identify a high-risk patient, we will go to the practice first and say, here are your high-risk patients. Here's what we think ought to be done for them. We have this conversation early in the year What do you think? And they'll go, you're spot on there. No, I'll take care of that patient. No, 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 you're drawing the wrong conclusions there. Here's what I know about that patient that won't show up in the data, and that's how we work it. That would become an even more effective process. So with that, you're talking about the ability to make better, faster, more accurate decisions with the ability to push this information out to the parties that actually can affect change more quickly. And, you know, to me, as I said, that would make use of some algorithms and relationships, interrelationships of data that we know work already, and a lot of others that we're guessing do, but really haven't effectively had time to test, or the data set or tool to be able to test that.
Okay, and a follow-up, because you kind of mentioned this, are algorithms already developed that will be used in conjunction with this project?
Oh, there are some that we absolutely have, okay, and would want to make use of. There are a lot of others that we'd like to be able to test, and if they're found, you know, to be useful, yes, to be integrated. And if we're able to if we find out that they're not, then dismissed. Think of it as a continuous improvement process in terms of being able to use this information effectively. Because for us, you know, we could drown in the data as we're able to pull all this together. So we've got to rely on existing algorithms and then a constant set of challenges to one another as to what other interrelationships help us better manage this population, particularly the rising risk early before they become, expensive. Yeah.
Okay.
I guess that's the best way to put it. I don't know if that's a good definition, but it's certainly one that works for me.
We've got a clarification question here. So it says, did I understand that some of the health systems are providing ADT feeds to you, but they're not being leveraged or correlated to beneficiaries in health endeavors?
That is correct. We get ADT feeds, and those essentially are usually provided directly to the local population health centers because they're typically co-located to the facilities, and we then move it up centrally. But again, it's another data set that then once we say, oh, you know, Mrs. Jones has just been discharged, you have to look to our health endeavors data to, to essentially, decide what those logical next steps are. So today you are right, they're not integrated.
Do all the hospitals give you ADT feeds?
Recently, it took us a while to get to that point, but the answer at this point is of the 4 major health systems, 2 have been doing it for a while. 1 started very recently. I think 1 we're still getting off the ground, but yes, we're starting to get it.
And that doesn't feed into the EHR of the practice. So then you have to let the practice know that their patient has been discharged. Yeah.
Yes. Okay. And you're talking about another area. In fact, I got a call from one of our physicians today complaining about a dropped handoff. And what I mean by that is patient was discharged. We got the ADT feed. They're supposed to let the physician practice know about that discharge as well, and then coordinate our follow-up services. Well, we went out, the ADT feed was provided, and we sent our paramedic out. And the physician found out, 3 weeks after the fact that we've been sending the paramedic out. We missed the report out, and he's missed an opportunity to bill a TCM visit, which is a highly profitable visit. So I had to explain to him how we were going to look at our process and make sure that didn't happen again. These are the types of things. This is the first time I'm aware of it happening, but these are sometimes the slips between cup and lip that will happen when you're working with different data sets, and people are approaching it in slightly different ways.
Okay, I've got something here, an option for this. Let's see. Could a viable solution be a vendor who aggregates multiple different EHRs or HIE information, so ADT feeds, clinical labs, etc., and mobilizes this information in real time to your staff, even if this vendor doesn't provide an analytical, say, dashboard?
Well, I think it's certainly the first step there. What we would need is still some ability to do the analyses, but that's the first big step. We can't get it all into one place. It would need to be something that we would then be able to analyze. The question would be, would there be something off the shelf that could go along with that that provided the analytic construct? Because to me, you know, we're looking for both, but I understand sometimes you might have strength in one or the other.
Okay, great. So this is about like kind of HIPAA compliancy and things. So since the solution will be HIPAA compliant, will the provider be expected to maintain the required approvals, or will those be maintained by TCT? And would it be okay for them to also request for relevant approvals from the patients?
Okay, here's the good news about the Medicare Shared Savings Program. We don't have to ask permission, okay? By virtue of assignment through the MSSP program, all we need to do is have signs up at each and every practice letting them know this is a participating practice in an MSSP, which happens to be TC2, and give them the option to opt out of their data, and usually a very small proportion of folks do. So on the notification side, every physician that's participating practice signs both a participation agreement, Medicare specified, and a BAA, a business associate agreement, particularly addressing, you know, protected health information, again, Medicare specified. And at that point, you know, there's the ability for us to get their information. They've already done the appropriate notifications. The only addition, and I should add, and that started this year, is Medicare did require us the first few weeks of January to send out a letter to these folks letting them know. So there should be no other need for notification about that. What we would need with any partner would obviously be a data sharing agreement, not only a contract, a data sharing agreement, and a business associates agreement. Essentially, you know, pull that organization into the structure that we already have. But that should be it.
Okay, great. A question about some of that clinical data. For the clinical data you're pulling from GHIC, I apologize if I'm saying that wrong. Is the data normalized within the HIE?
Okay, well, first off, let me be clear. We are not yet pulling information yet. And even though it looks like GHIC, they pronounce it GHIC, just the H is small.
I tried so hard.
Yeah, well, that's okay. Largely, it's just so they could say HIE at the end of it. Otherwise, you know, I thought it was a really bad idea, even when they first started with that. But at this point, we're not yet pulling. In fact, I think I mentioned earlier, we are about ready to start practice assessments to make sure, because these physicians have pretty much been running their own EHRs. A lot of them run on ECW, a lot of them run on a lot of different systems, but we are never 100% sure that they're putting the right data in the right place so that when things flow to an HIE, we actually are getting things where they should, you know, be arriving versus the old garbage in, garbage out. So between now and the end of the year, we will have done that assessment and essentially normalized those elements. So at this point, we don't pull that information. So when I talk about GHIC and care quality, I talk about that as something upcoming, but that will be upcoming next year. So, you know, it's imminent.
Hey, JC.
Great. Yeah, I was gonna say, I know we've got like only 10 minutes left. Why don't we shift this over to kind of some of the next steps? Of course, I've got more questions you guys have sent in. We maybe didn't cover everything, but if you do have last minute questions, please chat them while we're talking through next steps, and we'll try and get to them. How's that?
Perfect. Thank you.
Great.
So Chris, you're on.
And Isabel, if you want to share your screen a little bit.
I'm actually going to share my screen, if you don't mind.
Chris will share his. It's
Okay.
prettier.
Thank you very much, guys. Tell me if you can see the full screen.
Yep, we're good.
Yep.
Excellent. All right. Thank you, Dale. You're so specific about answering questions. It gives you a lot of confidence that you really know what you want and what you're looking for. So appreciate that. If you guys were on the program last Thursday night on the kickoff, you saw this, or you may have seen it on the website if you've clicked around the website. This is the 13-week program, the challenge, or the capital C, if you will, and it's broken into two phases. Phases one is a 5-week phase. The idea here is to talk with all the companies who are interested and down select to finalists for each of the two challenges. Phase two would be finalist preparation for the forward pitch. So if last Thursday was the reverse pitch, we're going to end with a forward pitch where the finalists, the 2 to 5 finalists for each challenge, will each have an opportunity to get on stage. That could be in person in Navicent's headquarters in Macon, or it could be via a virtual Zoom meeting again. But you'll have an opportunity to present to anybody and everybody who's interested. So the first phase here is on August 4th, as we stand here today. We've had 2 champion CEO Q&A sessions. And I'll cover a little about this more. The submission deadline is August 28th at 5 p.m. that Friday afternoon. And within 1 week, by the close of business the following Friday, we will have selected the finalists. Again, could be 2, 3, 4, or 5 finalists, if you will. And then we do have 3 additional coaching sessions at the beginning of phase 2, and a number of coaching CEO sessions, excuse me, and the number of coaching sessions throughout. And then we will have a dry run on October 22nd, a week before this one, because we want to make sure all the presenting companies are shining the best as they can. Let me spend a little bit more time on phase 1, which is the submission process. The coaching office hours will begin next week on Wednesday. It's going to be from 3 to 4 over the next 3 Wednesdays. Isabel Magnin, who's the quarterback of the selection team and who's been speaking today, Christopher Cunney with Georgia Hens, and A.T. Gimbel with ATV, and myself. This is Chris Carabinos with Tag Digital Health. We basically formed the selection committee. So the 4 of us, along with the 2 CEOs, form the selection committee. But the 4 of us will hold coaches hours. You're not required to attend these. You are welcome to. If you have questions about any of the process, about your submissions, and that kind of stuff, that's what we're here for. We are not necessarily subject matter experts like Dale and Laura. There is a process if you have additional questions for them after today. And so I'm going to show you in a second, but they're online. You can submit a question online, and we'll go through a weekly process where we share those with the respective CEOs, collect their answers, send them back out, and post them online too, because you want to make sure you get all your questions answered as you go through this process. Many of you, I think we've had 48 or 49 people in companies sign declaration of interest forms. I say sign, you just fill out a simple form. You don't have to before September 4th, but this helps us make sure that we reach out to everybody with the pediatric asthma solution who's interested, to make sure they have an opportunity to get their questions answered and to submit their proposal. And so I'll show you in a second where you can submit questions on the website. And then we also have a submission package, which I'll cover in the next page. So the proposal package or submission packet has these elements. We're not going to dictate whether it's Word or PowerPoint or Excel or whatever. We do want to include certain elements. And so again, this is also on the website. And then as you prepare this, you'll PDF it. There's a place on the website to basically submit it on the website. But we are looking for a company overview. If you're a company, I know we have some entrepreneurs who are looking at this, but whatever your team looks like, if you're revenue generating, what that looks like, some basic facts about your company would be helpful. Also, the contact information of the person's, the key person, or the key contact at your company that's sending this out, so we know who to communicate with. Indicate which challenge you're proposing on. Obviously, if you're doing both, we'd want 2 separate proposals, because we're going to have 2 processes, and Dale and Laura are going to take the lead on helping select those. So we want to make sure we have them separated in 2 stacks. You may have a very specific solution that you're looking at customizing to meet one of the challenges, or you may just have a general approach. Again, this is in late August. You're not expected to have a fully, completely operational solution in late August. We are looking to have you have a more complete solution by the forward pitch in late October. You actually don't need to have a fully operational solution until you go to beta. So if you win the forward pitch, the expectation is that you'll be ready to go to, oops, sorry about that. Trying to get rid of this little screen here. Into beta test with Navicent in January, sometime by the end of January. So, and that's one of the things in the proposal package that we'll be looking for is to, how do I get rid of this thing? To make sure that you're ready to go into test if you're selected in January. We'd also like a more detailed explanation about how your approach tackles the problem. And that's one reason why we want to give you a lot of exposure to the CEOs. Also give us an indication of how you would measure solving the problem. That's one of the questions somebody asked Dale and Laura, how they look at measuring. We'd also like your thoughts on how you think it could be and should be measured. We'd also like to know how long you think your solution in beta should last. If it's just a few weeks, that's fine. If it's 12 months, let us know that so we can understand, is that a 3, 6, or 9 month effort just in the beta piece, okay? And also, please share any assumptions that you have. Assumptions on the part of Navicent, you're assuming certain technical integrations or certain data sets are available, or you're assuming that you're going to be able to have access to something, so please share that as well, okay? So let me go ahead and show you the a couple of pages on the website so you know where to find some of the things I just mentioned here. So hopefully you've seen the website before. I've clicked on the resources page, and there's actually a lot of information here, including the key contacts, which is really us right here. This is the leadership team. And as we mentioned Thursday, and I'll mention it here again in case anybody didn't make it Thursday night, Isabel is the key contact for the selection committee. So you can submit questions down below, I'll show you, but if you want to reach out to her, you are welcome to do that. There's also some key documents a little further down. Once you get into phase 2, not for phase 1, but we'll ask you to sign the NDA and the BAA agreement. Here's the declaration of interest form that most of you have probably seen. If you haven't seen it, it's just right here on the same page. It's 8 bits of data just to share. It's real simple. And anytime during the process, phase 1 or phase 2, you want to submit a question, go ahead and put this in here. Who's it for? You can say a coach or champion and which challenge, and we'll route it to the right person. We'll get your questions answered before you can get it back. If you do want to watch the reverse pitch on July 30th, last Thursday, the entire hour and 20-minute recording is available here if you'd like to go back and see that too. As far as the proposal submission, here are the elements I referred to a little while ago. So you basically put in your name, contact, upload your PDF, and away you go. So we're trying to make it as easy as possible for you guys. If you have any questions about specifics about either challenge or the process, again, you send it to Isabel or send it via the question session there. Any questions for me? JC, any questions in the chat room?
I don't think so. There is one more question, but I'm going to go ahead and, because I want to be mindful of time. We've got 1 minute left. So what we'll do is we'll follow up, Tariq, afterwards with that, just to be mindful of everyone's time. And again, we will be trying to route these. There were some questions that came in that maybe we didn't get to, but Dale has seen them. And so we'll try and make sure that you guys do have all the information. But other than that, one question, what is the role of the coaches in this process? Maybe you could speak to that real quickly.
Yeah, no, that's a good question. I appreciate you asking that. So we're talking about the process and how to, we want to coach you guys up on how to best prepare your proposal for August 28th or August 29th. And also during phase 2, we'll be providing coaching on the finalists as they prepare to get their forward pitch. Some of you guys have given pitches before, some of you haven't. We want to make sure that you're looking polished and when you go up there. And so we'll help you think through some elements of how you're presenting things, how you articulate it. And so a number of us have actually done pitches before, and some of us are actually investors. So we sort of understand what buyers and investors are looking for, so we can help you through that process.
Great. Well, I appreciate that. I know we are 1 minute over time, but Dale, thank you for joining us. I know your time is very valuable, and everyone for joining. We're excited for the next steps. If you guys have any questions, submit them. We're here to answer all of them, and we will see you guys again soon, perhaps in a coaching session or something in the future. But I appreciate that, and we will let you guys go.
Thank you.
Thank you, everyone.
Thank you.
Bye.